Okay, we've got the COVID-19 vaccines. They are being distributed. There's talk about maybe sometime this year getting back to normal, or at least getting back to as close to our old normal lives as possible. In early September, I interviewed Dr. Anthony Harris. Dr. Harris is the Chief Innovation Officer and Associate Medical Director at WorkCare, a company that helps businesses with their infection prevention and control problems. WorkCare does a lot on the occupational health safety front. Hi, I'm Frank Diamond, the managing editor of Infection Control Today, where we want to give infection preventionists and other healthcare professionals the information that they need to deal with COVID, which is surging like crazy as I speak. I interviewed Dr. Harris for this broadcast back in early September, as I mentioned. Seems like a lifetime ago now, doesn't it? He said
Yeah.
that companies back then were concerned with things like proper airflow in buildings and how to go about COVID testing. Dr. Harris also said that those concerns, and I'm quoting Dr. Harris now, he said that those concerns will probably continue to shift as we talk about vaccinations and as waves of people become vaccinated. What's the strategy there? Dr. Harris, thanks so much for joining us here again at Infection Control Today.
Thank you so much. Pleasure to be here.
So I'll throw you the question that you predicted would come up. How do companies handle the whole vaccination process, or how should they handle the whole vaccination process?
Sure. So first and foremost, determining the approach to vaccine requirements for your workforce, right? And that's probably one of the most prominent considerations at this point in time, with the vaccine now being in that first 1A, 1B phase of distribution. And so when we talk about what's required and what's not, it's going to be industry specific. Obviously, healthcare, where you're having high interactions between the employee workforce and the general public, patients in this case, it's required. But consideration should be looked at in terms of those industries that have a lot of employee and customer or patron interactions. And those are the considerations that the company should maybe perhaps require vaccines for their workforce. And if we look at the opportunity from a legal standpoint, we know that ADA, EEOC, CDC have all kind of green-lighted that process for companies to make those requirements because it meets the litmus test that's been used in the past of an imminent threat, that COVID is an imminent threat in the workplace. And we'll see how it plays out with companies in regards to these requirements outside of the healthcare industry.
That's interesting. So you're saying that those agencies that you just mentioned have basically green-lighted an employer to say, you can't work for us unless you get the COVID vaccine. Is that an accurate paraphrase?
It is. It is. Now, EEOC has not come out and made a statement saying we are, clearly supporting requirements for mandated requirements for vaccination. Right? They haven't done that yet. It may be coming. But what they have said, what CDC has said, is that we know that employers have a requirement under the General Duty Clause of OSHA to keep the workforce safe, and this current pandemic, as some have been in the past, passes the litmus test for the definition of what's called a imminent threat. And because of that, companies then are permitted to require vaccinations. And interestingly, on the flip side of it, right, there may be litigation from the workforce if companies don't require vaccinations to keep everyone in the workplace safe because of that threat. And the litigation would follow because the companies would be called to the mat on not keeping their workforce safe under that general duty clause. So again, there's been legal arguments on both sides of the opportunity to protect the workforce with required versus voluntary vaccination.
I don't know if this is your bailiwick exactly, doctor, but I'd be interested in finding out what like strong unions would have to say about this. Like the teachers' unions are usually pretty strong unions. Some of the federal employee unions are pretty strong unions. Would they? I wonder where they stand at. It seems like they'd be caught in the middle in some ways.
Mhm. Yeah, so just from my own anecdotal experience with unions, through in my profession as occupational medicine specialist, right, we're seeing perhaps teacher unions come down on the conservative side, saying, look, we want to do everything within reason to keep our members safe, right? And we've seen it play out in cities amongst the workforce, teacher workforce, to say, look, we're going to continue to be remote. We want to be remotely teaching our students because of the risks of being in person. Likewise, it would follow that, hey, we see the vaccine as an opportunity to keep our workforce safe, our members safe. So we want to have that as an offering for those teachers. It may not be required, right? But certainly it would be something that they would push for in terms of access and early access as a means to protect their members.
I have to ask you this question. I asked at least one other expert this question. Did you get the vaccine if you haven't gotten it, or do you plan on getting it?
You betcha. Yeah, I received my vaccine several weeks ago. I get my second dose next Monday. I received the Pfizer vaccine. So you bet I'm going to be the front in the line, because I want to set the tone and the example for the physicians we work with across the country and our organization at work here, as well as the workforce that we work with, right? We take care of several million lives in terms of the touch that we have with the companies we support. And we want to continue to undergird the safety of the vaccines, Moderna, the Pfizer, and the efficacy, because at the end of the day, the magic number here in the US to reach that herd immunity is approximately 196 million individuals, either from natural immunity, having recovered from COVID, or vaccinated. And we're not going to get there anytime soon if we don't have people lining up to receive the vaccine. And if you look at the polls, it's as few as 40 to 60% say they'll actually get the vaccine in the general public. And we need higher numbers than that, because again, it's not going to be everyone who develops immunity from these vaccines itself.
When you get the first dose, are you limited to what you can do and what interactions you can have with people until you actually get the second dose? How does that work? And does it work with the vaccine?
Sure. So the numbers play out in terms of risk, right? And what the efficacy of each vaccine is, which determines kind of you call it safety level, if you would, or the number of precautions you need to take from a personal health standpoint, right? So if you get that first dose of Pfizer or Moderna, you're about 80% likely to have developed immunity. If you look at the phase 3 clinical trials, after that second dose, you're about 95%, right? So meaning 5% of people after the second dose may not have immunity with that vaccine. If we look at AstraZeneca, that number is much lower in terms of the number of people who respond to the vaccine. Only 70% efficaciousness for the AstraZeneca. 30% of people may not be immune after their second dose of AstraZeneca. So in terms of the practicality of a day-to-day precaution for an individual who's received the vaccine, myself included, still have to wear a mask, still have to practice safe social distancing, because until such time that we're on the other side of having most people vaccinated and we start to measure the immune response, i.e. what's called a titer, if you're familiar with how vaccines have worked in the past, that titer will say, yes, I've taken your blood, I see the immune cells or the antibodies in your blood against COVID, and you should be protected, right? It won't be until we have a use case like that more prominent in the general public that we'll probably start dialing back on precautions. And so far, we are not just this year away from it, but well into next year before we see those type of changes.
Now, these vaccines were granted under emergency use authorization by the FDA.
Mm-hmm.
Does that kind of possibly temper what employers can expect from employees as far as getting the vaccine? I mean, can a logical, as you mentioned, only about 60% say they will get the vaccine. Can a logical response be, well, I don't know if this vaccine really is going to be good for me, or it's granted under an emergency use authorization, and it hasn't been really tried over a long period of time, having studied over a long period of time with large populations. Are any of those you think hold water in terms of resistance to getting the vaccine? As you know better than I do, you're a doctor. The anti-vax movement has been growing like mad in the last couple decades.
Yeah, so in terms of that FDA EUA, or emergency use authorization, and the kind of inference from that, right? Does that denote any higher level of, any lower level of safety than the full application and approval of a medication, in this case, the COVID vaccine? And the answer is not as far as we know, right? These manufacturers, Pfizer, Moderna, AstraZeneca, will still need to apply and receive their full approval from FDA, not just EUA. But if we look at the robustness of the clinical data, the phase 3 clinical trials, I mean, we're talking a powerful study that we would normally see in the full process done much more quickly. So from a safety profile standpoint, the mRNA vaccines, Moderna and Pfizer, have a far lower side effect profile than a lot of the common mainstream vaccines that we've been getting for decades, right? And so it's that body of data that allows us in the clinical community to say, look, these vaccines are safe. But you're right, to your point earlier, we don't know the long-term effects from these vaccines. The mRNA vaccine is new. First time it's been approved for use in the US. And so we'll see how clinically things play out over time, but there is no evidence to suggest that mRNA vaccines would cause any long-term side effects because of the very nature of how the vaccine functions in the human body.
Do you think that this might become every year thing or every 2-year thing, like the flu vaccination now is currently kind of?
It's likely, right? If we look at the seasonality potential of COVID, it's there, and it'll track with the flu season as well. And many have speculated that even back in the spring and the summertime. And what even Tony Fauci has said is we'll be likely dealing with COVID for 5 years at a minimum, with the cyclic nature of mutations that occur called genetic drift and genetic shifts that we're seeing now in COVID, right? These new strains out of the UK, the strains out of South Africa, right? We've been seeing these strains from day one out of Wuhan, China, when there was only 2 strains identified at that point in time, the S and the N strain. But now we have multiple what are called clades, families of mutations that have propagated around the world. And because of that, it may happen that each season we have to re-up on our vaccines with a different formulation, just like we do with the flu. But we'll see how it plays out with this round of vaccines, protecting from the different mutations that are coming out that we're identifying. They should still be efficacious, but long-term, over the course of another year, the mutations may be substantial enough on that spike protein, which allows the virus to enter our cells, that our antibodies don't recognize it. And so we'll find that out over time for sure.
I guess a 2-part question. How many people have to be vaccinated? I have heard everything from 80% to 90%. And the second part of the question is, were you surprised by how fast they got the vaccines out? I mean,
Sure.
It's kind of fashionable to paint the pharmaceutical companies as bad guys. We have a story, full disclosure, we have a story on our website today saying that they actually came through, the scientists and researchers came through as heroes in this situation. I don't want to put you on the spot. But were you surprised at how fast they reacted and how fast they got a vaccine together?
No, not at all, actually. And, we know that, yes, traditionally, it can take up to 10 years for an FDA approval for a pharmaceutical, right? And that process is not necessarily predicated on time intervals that are hard and fast, right? We know that there are some there in the US and abroad, Australia, the UK, that have definitive timetables that you must adhere to. However, a lot of it is resource dependent, right? And so what we have seen in terms of this concerted effort is a lot more resources, federal government included with the Warp Speed program, poured into the effort to develop these vaccines. And so instead of having a more slow, gradual ramp up from a resource standpoint, it accelerated because of the increased attention and increased dumping of resources into these programs. The key, though, is, were the studies robust enough? Did they have a high enough number of participants to really understand what are the potential untoward effects of these vaccines? And the answer to that is yes. To the extent that we have done so, and comparatively with a longer process, we can still say that the side effects are few and these vaccines are safe. To the other point of the question in regards to long-term, well, go ahead, reiterate the second part of the question. I want to make sure I nail that one
First,
specifically.
Is it 80% or 90% that need to be?
Yeah. The herd immunity number. So that number is dependent on what's called the reproductive rate of the virus, or not, right? And if we look at that reproductive rate, if it's reproductive rate, just means how many people are infected on average by one person with COVID. So if the reproductive rate, which it is right now nationwide, between 1.2, 1.5, meaning 1.2 to 1.5 people are affected by one person with COVID. If we look at some states and some cities, that our number is as high as 5 in some studies, right? Meaning 5 people are infected by one person on average. And that means a greater number of people need to be vaccinated or have immunity to reach that herd immunity. So if the number is 1.2, herd immunity happens around 40%. If the number is more realistically around 2.5, then the number jumps up to 60% need to be vaccinated. Again, we are woefully, the data is showing, we are woefully underestimating the true burden of COVID in the US because we just don't have enough testing going on. And what that means is that we're probably sitting more closer to that R naught of 4 to 5, meaning 80% of people need to be vaccinated, right? So we'll see, where we land at the end of the day after these new strains and the new levels of infectiousness are fully understood. But I would anticipate, as most experts are, 65% is the minimum we need to reach, but it may be as high as 80%.
You mentioned the new strains a couple of times, and that's gotten everybody's attention. Unfortunately,
Sure.
The one in the UK was a B1117, I think it's called, and the other one that was in the South Africa, I think is, I forget, 504Y something or other. The UK one, they say is like possibly 70% more infectious. The other one, they're still trying to figure out what's going on with that one. As far as I know, you're more up in this than I am. But question: do these strains concern you? Are you worried about this?
No. So from a clinical standpoint, in terms of severity of illness, that this new strain, the UK strain, as you mentioned, B1117, has not been shown to have people develop more severe illness, right? It may be more infectious in terms of how quickly it can be communicated, as we've seen before with the N strain of the virus back in Wuhan, China. So in terms of overall concern that we're going to see a shift in regards to how we have been experiencing COVID-19, no, I'm not very concerned because we've seen this before. This particular strain, again, is identified recently, the South African strain identified recently, but again, we have a myriad of, I believe there's over 11 different clades or families of mutations that have occurred thus far. Some literature says 18 times the spike protein is already mutated. So it's not alarming that it's happening. And so far, it's not alarming because it hasn't caused any more severeness of illness. And to the contrary, it actually may cause less severe illness, even though it's more transmissible, if you would. So we'll see how it plays out in terms of a safety standpoint. The same precautions should protect us from this strain and other strains with the social distancing, the wearing the masks. That's key.
As you know, finally, a big portion of my audiences comprises infectionists, many of whom have a nursing background, but we're going to be publishing a story in an upcoming issue that they're going to be heavily involved in vaccination and the vaccination efforts in their healthcare facilities. Just like for a lot of them are heavily involved in the flu vaccination efforts. Not that some of them do not have nursing backgrounds, so they can't actually give the injection itself, but I mean administratively. So sorry, long lead into to a short question. What will their role be, you think, as the vaccinations are rolled out?
Sure, they'll be on the front lines. I definitely, administering the vaccines, and they'll continue to be on the front lines. Obviously, caring for patients that are being on the intake side of things into the clinical care. But also, I think as we see programs developed around keeping the general public safe, the workforce safe, they're going to be front lines again, drawing blood and looking at antibodies. Towards the end of this year, beginning of next year, confirming that hey, our vaccination efforts are working, and we're trying to understand how long people are indeed immune to COVID once they receive the vaccine, once they recovered from an infection of COVID. So there's a number of ways that these professionals are going to be continue to be on the front lines, helping us fully understand the impact of COVID-19 and get to the other side of it for sure.
Dr. Anthony Harris, thank you so much again for visiting Infection Control today.
My pleasure. Thank you so much. Would love to do it again for sure.